Perfect. Thanks, Jenna. And thanks to everyone for joining us today. I am very pleased to introduce Lauren Wolfe. Lauren graduated nursing school in 1990 in South Africa and moved to Canada shortly thereafter. Lauren has worked in the spinal cord injury unit at Shaughnessy Hospital back in the day. She was there for 7 years, and she looks back at those times as some of the best years of her nursing career. In 1996, she completed her intensive care certificate working as an ICU nurse at St. Paul's. And it was there that she developed a real passion for wounds and ostomy, which led to her to attend Emory University and completed her wound ostomy and continence, that's shortened to WOCN certificate, in 2006. Lauren established the WOCN program at Richmond Hospital, and in 2011, she moved into community nursing care, and there expanded her knowledge, caring for individuals with wound, ostomy, and continence concerns. This past year, in 2020, she completed her Master's of Clinical Science in Wound Healing at Western University back in Ontario. Go Mustangs. And currently, Lauren holds her clinic at McDonald's Prescriptions, that's Vancouver, down on Broadway near Willow, and while also working part-time at VGH on the WOCN team. Lauren has a passion for assisting clients with SCI injuries and with their wound, ostomy, and continence concerns. She is a recognized expert in the field. She has a strong knowledge in helping individuals find the right ostomy pouching system, allowing individuals to become independent in their bowel and bladder management. She was the recipient of the CRNBC Award for Nursing Excellence in 2011. She is a dedicated and compassionate nurse who always strives for excellent patient care. Lauren is a leader in her field and amongst her peers, passionate about advancing the practice of WOCN nursing. She has presented at various medical conferences, has published many articles and posters, and today I'm pleased and honored to have her with us and to present. So without any further ado, please welcome our speaker, Lauren Wolfe.
Hi, everyone. Fraser, Jenna, thank you for those introductions. That's really lovely of you. So today we're going to be speaking about what I consider gaining your independence back when you have a spinal cord injury. I'm having a bit of trouble with my slide advance, so be patient. Just to be transparent, Hollister is supporting this presentation today. I'm just going to I'm going to minimize all of you. So I'm talking to a screen, which may be a little difficult, but otherwise I can't see my slides very clearly. So the objectives today are understanding what an ostomy is. For many of you, this is new. Understanding the benefits of having an ostomy when you have a spinal cord injury, navigating what that ostomy journey is going to look like, and then understanding how to regain your bowel and possibly bladder independence as well. The first thing I did was try to do a little bit of a literature review to see what was out there. And there wasn't a lot of studies, but I included what's called a systematic review, where they looked at an overall number of studies. And there were 15 studies they looked at, of which 12 were assessing patient satisfaction with having their ostomy. And really, of the 15, 12 reported a high patient satisfaction. And I can actually mirror that because I have a number of spinal cord injured patients, about 4 in my clinic. And all of them, as you'll see by the words that they speak to during the presentation, mirror this high patient satisfaction. So I just want to disclose that throughout this presentation, you'll hear from 2 spinal cord injured individuals with elective stomas. These individuals have elected to remain anonymous, and the voice recordings have been modified. Now, these 2 pictures individuals here are actually off the internet. They don't represent any individuals. The first thing we want to do is look a little bit at anatomy as well as understanding what an ostomy is, because the word ostomy and stoma are used interchangeably. Stoma means an opening in the body, and ostomy often just refers to part of the bowel in a sense. And you can have both fecal and urinary stomas. And over the course of my career, I've had patients with both when they have spinal cord injury. The more common for urinary without a spinal cord injury is bladder cancer. For fecal without a spinal cord injury, it's your inflammatory bowel disease and then cancer as well. I lost my... So looking at the anatomy, now I don't know what everybody's level of understanding is. We have the large intestine. Okay, and most commonly when my spinal cord injury patients have an ostomy, it's sitting in this part here called the descending or the sigmoid colon. I hope you can see my little mouse pointer. And that portion of the intestine can be brought out to the skin level. Now, if we look at the urinary system, we have our two kidneys and we have the bladder. They don't need to remove the bladder when it comes to having an ostomy for a spinal cord injury, because your bladder is not diseased, but they may choose to remove it. That would be a discussion with the physician. What they do is take a piece of the small intestine and make a little conduit, and then they attach these ureters to it and create a stoma to the outside of the body. It's not a very common procedure in the spinal cord injured population, though. So urinary stomas, if you're going to have them done, tend to be more appealing to women because of the challenges with catheterization. However, very often patients will initially go and have a suprapubic catheter done. It's much less invasive. It's not a big surgery. And so most of the time, I think of all my SCI patients, I've only ever had one that I know of that's had a urinary catheter done. And as I mentioned, it's because of the need to bypass the bladder or possibly remove it. So if we look and focus more on fecal stomas, which is what I think a lot of the group is interested in listening to, you can have an end stoma or a loop stoma. So what does this mean? An end stoma means that when they take the bowel, they will do a complete break in the intestine and bring the end that goes all the way back up to your stomach and your mouth. They'll bring that piece out to the skin level, and they'll turn it inside out and make it look like a pretty little rosebud, like at the bottom here. And then if we're looking at a loop stoma, they bring the intestine out literally as a loop, you can see here. So there's two openings, but only one of them will be an active opening for actual fecal matter. The other will produce mucus. The nice thing with this picture and with the stoma here is that you'll see that both the openings are quite raised. And that's really important when it comes to having an ostomy, because even when it puts out mucus, it can affect the pouching system. It's difficult to see, but in this bottom picture, here's one opening and the other opening is buried at the top over here. It's not that visible. So we're going on to our first audio clip. This is, as I said, not the patient's actual voice.
There were a lot of reasons I decided to get an ostomy. It was rather multifaceted. In my situation, being a quadriplegic with a spinal cord injury, my bowel routine was very long, unpredictable, quite arduous. It took up a lot of my time that I could have spent doing other things I enjoyed in life. And there was never really a guarantee that I wouldn't have a bowel issue to deal with later on in the day. After years of all the transferring, I developed shoulder rotator cuff injuries. That made it really difficult to transfer to do my bowel routine. Over the many years of doing this routine, I also developed severe hemorrhoid issues, which led to immense bleeding to the point it even made me iron deficient. Add in the fact that I ended up with not only IBS issues, but also a lot of anxiety. The fact that I could never be guaranteed that there wouldn't be a bowel issue throughout the day. I decided what I wanted to do was enjoy life without having to go through all of this. I researched this option and spoke to people in similar situations via phone, actually meeting with a few people in person. And it became very evident after talking to all these people and speaking with Lauren. For someone in my situation, an ostomy surgery to me was just a no-brainer. Looking back, my only regret is that I didn't do it sooner. I now live with a peace of mind and high quality of life, free from that anxiety and the daily bowel struggles since I've done an ostomy.
So moving on, what we're now going to do is look at the steps that it takes in the journey of getting an ostomy and how you choose to make that decision. And we're going to go into these in much more detail, but step one is making that decision. Step two is the referral to a surgeon. Step three is stoma marking. Step four is the hospital stay. And step five is the post-surgical journey. Now, these are steps that I've created. You're not going to find this in the literature, but they're the steps I use when I'm talking to individuals with ostomies. So if we look at step one, about who to talk to and what information you're sort of looking for, the first thing is a stoma nurse. Now you're going to see lots of number or letters up there: stoma nurse, NSWOC, WOCN. We're all the same thing. And just to clarify, NSWOC stands for Nurse Specialized in Wound Ostomy Continence. Those nurses are Canadian trained, and it's the designate acronym that we use in Canada. So even though I'm American trained and I'm a WOCN, Wound Ostomy Continence nurse, you'll see on my title, I still use both of those. I have a C in front of mine. It means I've taken the American certification exams, and I do that every 5 years. So what is that stoma nurse going to do? The stoma nurse is going to answer your questions. We are the most knowledgeable group of people who can help you navigate what that journey is going to look like, answer all the types of questions, whether it's from the surgery all the way through to the pouching, to where to purchase supplies, to how much do supplies cost, do they cost supplies, and really any random questions you may have. Very important to speak to your surgeon. As nurses, we are not medical professionals, so we may not know your other comorbidities, what your risk factors are for surgery, and you need to speak to probably your GP, and then you need a surgical referral to a surgeon and have that discussion at a fairly soon, or at least initiate the appointment fairly early on, because it does take a while to get an appointment. I encourage you to speak to other spinal cord injured patients, and I know people who have reached out to me. I've referred them to others. It's always at the permission of both individuals to share the contact information, because I'm a nurse. I'm not living life with an ostomy. I'm on the other side where I'm able to help, but it's important to speak to people who are living with ostomies. And then other patients, perhaps other patients who don't have spinal cord injury, may be of benefit as well. And if you can, if you have a community nurse, speak to that community nurse as well. They're not as knowledgeable as your stoma nurse, but they may be able to help you navigate, especially if you formed a relationship with them, because they're going to be your contact once you go home. When it comes to the surgical team, you need an experienced surgeon. I have to say that there are different surgeons out there who make different types of ostomies, and it's really important that the stoma creation is prominent. So if you look at this individual stoma on the abdomen, it's standing up beautifully. You can see it, it's in a place that's visible. It's actually a bit higher than the average marking on an able-bodied person, because when you're sitting in your chair, that's when you're going to be changing your appliance, emptying it, all those factors. So you need to be able to see it, and it can't be lower down. So on an able-bodied person, it's usually a good few centimeters down. Encourage the surgeon, if they don't work with stoma nurses, connect with that stoma nurse, and they need to use the stoma nurse's marking. Now, on the other hand, there are times medically that they can't. So that discussion needs to happen with the surgeon often and the stoma nurse to ensure, what if they can't use the marking? What are we going to do? And I do think it's important that the surgeon is understanding on the level of injury you have and how much hand coordination. Because again, if you are a level C5, C4, C6, you need that prominent stoma, great location, because otherwise you're going to struggle. If you're paraplegic, have full hand-eye coordination, it will be a little bit less of a problem. So my second patient, I didn't do a voice recording for him, so I'm going to read you his words. If you're thinking about it, make an appointment with the surgeon, because that takes a long time. You can always decide that you don't want to do it anywhere along in the process. You don't want to spend a considerable amount of time making the decision to get a colostomy and then have to wait a year or two in order to get it done. So the pre-op journey, now this is my recollection of my one patient, the one with the voice recording of what transpired. So we had about 3 to 4 pre-surgical visits, which is much higher than the average patient would have. And to me, that's totally fine. There can never be too many questions asked. You want to have all your fears, all your questions asked in this pre-op period, because it's a big decision you're making. So things like we just showed you is, how is that stoma created? And I can repeat myself over and over if you're unsure, and we go back through the anatomy, we pull up more images. The big question was, how frequent will my bowel movements be? Will people be able to see my stoma? That was a really big question. One that all patients ask is, will I smell? How will I know which company's product to use? What if I can't change the pouch myself? Will I be independent? Clothing and visibility, funding. So I hope that the rest of the presentation will cover all of these factors. So now we're going to listen to the second audio clip.
There were 3 or 4 pre-surgical visits, and that was really to help gain some sort of a comfort level with everything that was to come. It was an introduction of sorts of what was all involved with having an ostomy, and to answer some questions like, what was the maintenance after I had the surgery? And what about dealing with the pouch? I had a few trials on a fake stoma just to make sure I'd be able to change the pouch and deal with all the other things that would now be involved so I could keep my independence. There was also a chance to go through all the options, all the products available, and look at what was the best option product for me moving forward. And of course, there was the decision to where the stoma would be located once my surgery was done.
So you can see what my patient is saying very much mirrors what I mentioned. So when it comes to the stoma marking, key factors with it are, you must be marked in your chair. So usually what happens is, even if you were to come and see me in my private clinic, we would do a lot of the pre-op discussions, answer all your questions. Whichever hospital you go to, you will have a pre-op appointment with the wound ostomy continence nurses or NSWOCs there, and they will be the one marking you. At that appointment, unless you wanted me to mark you, which I'm totally happy to do. In fact, I did mark this patient. I want you to remember to tell them you're in a wheelchair, because right now with COVID, we are marking people immediately pre-surgery, literally 20 minutes before you go, and you're on a stretcher and we don't have access to your wheelchair. So what needs to happen if you were to come to VGH is you would need to be seen in the clinic, which is a possibility even with COVID, to be marked. But because we're not seeing you, we may not recognize you're in a chair. They're often phone consults, not even Zoom. But I'm happy to mark people in the wheelchair. One of the big things with that stoma marking appointment and the pre-op appointments is developing a rapport. It's probably the biggest thing. It sounds crazy, but it is. When I was doing my wound ostomy schooling, was develop that relationship with the patient, because you're going to be the person they connect with through the rest of their journey of living with the stoma. As I mentioned, you must be able to see the marking. It will be higher than able-bodied. You want to plan for aging, and a few of you may be laughing here, but as we age, our bodies change and our tummies get bigger and things drop. And so we need to, as I said, have it higher. So even for an able-bodied person, I'm going to consider aging and what may happen, especially guys who like to drink their beer and get those beer bellies. And for me, you need an experienced stoma nurse. So you may not know what their level of experience is, but I have to say that I have seen the odd marking that I would have gone a couple of centimeters higher, and I think it would have made a difference. So my other patient, who's a C5-6 quad, these are his words: knowing what to expect was vital in feeling as comfortable as possible with the process. Recovery time and process was important to know. Understanding what it will look like and how it will change over the first few months was important. It was nice to know where it would be located and how it would be marked for surgery. Making sure it would be in the same location we had discussed was important, so that I'd be able to manage it as independently as possible. Having it located in a position that I couldn't manage would have been disastrous. So that patient actually, before I go on to a hospital stay, is now independent, even though he has quite limited hand function. We have managed to achieve independence, which has thrilled me, because it was something I did mention to him in our visits that, you know, I can't always guarantee that, but I'm going to strive for independence. The hospital stay is probably the least of your problems. And in fact, what I want to say is, it's more about you not losing function, as well as not developing any pressure injuries during that time. So the importance of telling that nurse that you meet that you need an air loss mattress while you're in the hospital, tell your nurses on the unit to turn you if you're not able to turn yourself. You will be seen by a stoma nurse, depending which hospital, and you know, the VGH team, we will be up to 8 people starting in October, actually November. So it could be any one of those if it's Vancouver General. They will assess your stoma, they'll create your initial care plan, and they'll help to plan your discharge. And if you haven't already connected with a stoma nurse in the private sector, they'll help you select one and organize where to get supplies from through that nurse. Your stoma is going to change a lot. So it's really in that first few days of being in hospital, you're not going to do anything. And it's going to take a number of weeks before you gain independence, weeks to months probably. So for me, the biggest thing is actually to get you in and out of hospital as fast as we can, because as the wound care side of me is worried about is you're out of your normal environment and you're at a higher risk of pressure injuries. So I want you home as fast as possible. So our next audio clip.
As far as my surgical experience, well, there's a bowel prep the day before, which isn't the most pleasant thing in the world. But as far as the actual surgery is concerned, everything went smoothly for me. Dr. Maloche was an incredibly understanding and caring doctor. It made things so much easier. He would answer all my questions, and I never felt that he was rushing me. It just felt really well taken care of. And it was pretty straightforward. I went to admitting, then they prepped me, ready to go into the OR, and away I went. Next thing I knew, I woke up with a colostomy. I don't recall any side effects whatsoever.
So what is this post-op journey going to look like? Well, first, before I even touch on that, I want you to know you need to be patient because it takes time in gaining that independence. It is not an overnight thing. Initially, the stoma is going to be edematous, which means quite swollen. Your bowel movements are going to be erratic. You may still have a little bit of rectal discharge of any leftover stool, poop, that's in the lower colon, so that's not uncommon. Over the next few weeks, the stoma is going to stabilize and your bowel movements are going to start to regulate. At about 6 to 8 weeks, your stoma should stop shrinking, and then we work further on the bowel regulation. And that's going to depend on your body. For some people, it happens fairly quickly. For others, it may take a number of months. It depends on what you eat. Your bowels, in my eyes, have been traumatized over the years from all the bowel prep that you've been having. And so now we need to figure out what we're going to do. The odd patient of mine will still take some senna to regulate. We avoid the Colace or the stool softeners on average. And we're trying to figure out now, can we get to once or twice a day bowel movements? But it can take a number of months. And so I'm not kidding when I say you need to be patient. This journey will take time. So what is the hospital discharge? What was important to my first patient that we spoke, the audio clip patient, is to have the right supplies to go home with after discharge. The hospital also had me set up with an ostomy nurse while I was there to oversee things and make sure I had nursing set up in the community for the first little while after I was discharged. It was a massive weight lifted off my shoulders. So, in the hospital, we give you a little kit and we give you some supplies to tide you over until you can see your ostomy nurse in the community. Because once you're up in your chair, your body contours are very different. And what you may use lying in bed initially after the surgery, your tummy's swollen from the surgery, will be very different in a couple of weeks. So we don't give you a lot of supplies, but enough to tide you over initially till you meet your ostomy nurse again. So now comes the post-surgical journey and working towards independence. And I want to say that this is probably the part that we need to spend the most time on, because this is going to take, as I said, a number of weeks to months. Things that we need to consider if we look at starting at the bottom of this pyramid is dexterity. What is your dexterity? Now, if you're connecting back with that same stoma nurse who you went to for the questions, you're going to already have troubleshooted your dexterity. For me, I would have given you different companies' pouching systems to try to see if we can determine already in the pre-op stage which company works better for you. Because as you'll see in a bit, there are different companies and everyone's an individual and you all have different levels of dexterity. The next thing is we're going to, as I mentioned, look at your stoma. What does the stoma look like for you? Because we knew what we wanted pre-op, but what has actually happened post-op? Is it that big, beautiful rosebud that I want it to be? As I said, looking at the different pouching systems now. So pulling in, what does that stoma look like compared to your dexterity? Because if things were different than what we predicted, we may need to alter the pouching system. You may need accessories, and by accessories, what I mean are there are like washer rings, like that they call barrier rings, adhesive remover. I try to minimize them as much as I can because many of you are facing dexterity issues, and the more things we add on, the harder it makes the pouching system. So looking at what do you need versus what is out there on the market. Revisiting your diet, because if you have getting a colostomy, now this is predominantly colostomy, but all of this except diet applies to urostomy, which is a urine stoma. But looking at the diet, we want to work with your diet to decrease gas formation, to increase fiber eventually, not in the first few days to weeks, but definitely, after 3 to 4 weeks, looking at that diet to try to keep you off bowel medication and get you regulated with nice, fairly solid poops. What is your funding? And we'll go into more detail on funding in a minute. And then back again, your knowledgeable stoma nurse. And that nurse, male or female, is going to review all of this with you and help you navigate that journey. And it's just really important to have a knowledgeable stoma nurse. So again, just speaking to this again is familiarity with products for the stoma nurse. Not all ostomy nurses are that familiar with all the company's products. The funding, what is the cost to you? As I said, diet is regulating. The accessories I mentioned, less is best. The pouching system based on your hand function and actually your stoma. The stoma, what does it look like? Is it visibly protruding? Is it flat? Is it recessed? I haven't even discussed those because I want us to go into this thinking we're going to get a beautiful prominent stoma with the surgeon, and then your dexterity, which is going to guide your independence. So our next audio recording.
As for my post-op experience, well, the positives were I never had to do that long, time-consuming and unpredictable bowel routine that caused the excessive bleeding, dysreflexia, all the hemorrhoid issues, all that anxiety. I never had to do that ever again. I was grateful to have Lauren and all her experience and expertise. I could lean on her, whether by phone or office visit, for advice, for counseling on how to deal with any situation that may arise. I was set up with the right supplies to go home with after discharge. The hospital had also assigned me an ostomy nurse while I was there, just to oversee things through discharge and make sure I had nursing set up in the community for when I got home. It was a massive weight lifted off my shoulders. It has given me the freedom I was hoping for, just to go about my day without worries. And I feel like I've been given the tools to deal with my ostomy as needed. I learned this quite quickly. Always carry supplies with you. It does take a little time just to learn the products, the different systems available, but once you've had time to practice, it really just becomes second nature. The challenges I had was just learning how to get a proper seal with the pouch and learning about the products. I started with a 2-piece system. I had some issues with some skin irritation. There was the odd stool leak, which was contained under the phalange. Once I switched to a 1-piece system, my skin has been so much better, just because it gets cleaned a couple of times a day when I change my pouch.
Before we get on to the pouching, I just wanted to say with the audio, I did not bribe my patient to say all of these. This is truly his words. I just prompted some questions to guide what the audio clip, like the post-op journey, the pre-op, that type of things. But I did not prompt any of what he's saying. I think that's important to know because he really has been very happy, as you'll see. So these are drainable pouches. Now this is a 1-piece drainable pouch, and I just wanted to show you some pictures. These are 3 different companies. Hollister is on the left, and then we've got Salts and Coloplast. And again, I thank Hollister for sponsoring this event today. And Hollister is quite aware that it's about what system works for you as an individual. And we want you to recognize that just because one company is sponsoring this, we're not going to push you into a pouching system that may not work for you. All of these has pros and cons, and it's really about finding out which system works for your body, your stoma, your skin, your dexterity. These are one-piece systems versus the two-piece that we had spoken about. I didn't put pictures of a two-piece in though. These are urostomy pouches now. And so I have not, I'll be honest, my patient that had a urostomy was a paraplegic. So I have not had the opportunity to work with a quadriplegic and to determine level of dexterity. Off the top of my head, I would probably take out the middle one as being challenging because of the tap at the bottom. I think the other two are definitely workable in managing the tap. And often they connected to leg bags, which most of you are familiar with. And then it becomes how you remove the backing off of the pouching systems of the sticky part. These are the closed pouching systems, and you'll see a picture shortly of my individual wearing the pouching system. And again, we start with different ones and we look to see which one is going to work for you. And it can be a varying on, as I said, the skin, as well as how you take the plastic off the back, and then also your prominent stoma. And on a closed pouch, the gas filter is important and how much gas you're producing. So here you can see a pouching system on my individual patient and where it would be located on your body. So for some, it may be high, but you can see with the belt line, there's no way we could ever have it below your belt line. It's just not possible. But this is a one-piece closed system on that individual. Let's talk a little bit about funding, because that's really important. I don't know how much all of you know about British Columbia and the funding. So if there are any people who are not from British Columbia on this, this is specific to BC. When it comes to ostomy and medications, everyone should be registered for what's called BC Fair Pharmacare. And I say that regardless of your income, whether you're ministry funded or whether you are working and are, earning 100,000, because you never know what's going to happen to you in between that. BC Fair Pharmacare has a deductible system based on your income level. So if you're ministry funded, you will get everything paid for you. If you are not ministry funding, you're going to find you have a deductible, and that deductible will be 3% of your income. You'll be 70% covered for medication and ostomy. And then at 4% of your income, you'll be 100% covered. If you have private insurance, they will pick up the balance. So as you're working towards your deductible, they will pick up anywhere between 80 and 100%, depending on the coverage that you have through your private insurance. That is whatever that insurance is. You don't really have a say in that one. But they do want you registered for BC Fair Pharmacare, because once you've reached your BC Fair Pharmacare deductible, they don't want to be paying. So many of them do check to make sure you are registered. Once you have, actually no, the private insurance, some people I understand have a max out. I'm not very clear on that. So it would be something you want to look into if you do max it out. The thing to note that if you are a working individual and you retire, you may lose some of your private insurance. Or you would negotiate a different plan, and that's important. And this is regardless of your injury. This is for every person in BC. If you do not have private insurance and you do not qualify for BC Fair Pharmacare, you are paying out of pocket for all of these supplies, and you can put them on your tax return. I'm not aware that just because you have a disability that you'll be funded. It is only if you are ministry, meaning low income. you already probably are receiving the disability tax credit, so you can't get it twice. For able-bodied individuals, they are able to then apply for the disability tax credit. So if you haven't applied for that, you should. And then the other thing you are eligible for is all those other disability plans, registered disability saving plans, etc., which I would really advise you to take up on that. But the funding is important, and this is something, again, that should be discussed with your ostomy nurse, that they can help you navigate, because you may choose a pouching system that may be a little bit cheaper than another company's, and they can help you figure that part out as well. They are all priced differently. So moving on to regulating your bowels. Well, this is a challenging issue. This is a challenging issue for you right now. And it can be disheartening in the beginning, because I think one of the biggest things that we want to have regular bowel movements right away. And it does take time. You've firstly had a surgery. Everyone's bowels go crazy when they've had surgery. You've had that bowel prep, then you sometimes you develop what's called an ileus, where your bowels don't start working for a while. So it does take a period of time, and you need to be patient. Keep a food and bowel movement diary that we can determine, and in food and water, drinks and things, we can try and figure out what foods you're eating that may be causing you too much gas, that may be causing you frequency, maybe not enough water. Everybody's body is different. And I don't know if you do this now, but foods that cause gas for me may not be the same foods for you. There are a lot of foods that are common in causing gas, but I'll be personal here. For me, when I eat lettuce, it's deadly for me. Other people look at me like I'm crazy. They've never heard of that before. So I'm very cautious about when I'm eating things. And the importance with gas is you don't want to blow off that pouch. If we're not able to get your body regulated, oftentimes I'm going to send you to a dietitian if you're not already seeing one, and then we may consider Senna. All right, but don't worry, we don't do suppositories. You could do what's called an irrigation, but many of you have already been doing all of that, and it's about the last thing you want to do. But it's definitely something you could talk to your stoma nurse about. If you want to do a bowel routine using irrigation, you can do it through a stoma. But from my understanding, most don't want to do it. And even able-bodied people don't want to do it because of the time it takes. So we'd look at Senna, we'd look at adding on Metamucil, some of the added fiber. Really important to drink fluids and eat a fibrous diet to bulk up your stool, but only after about 6 weeks. And then, as I say, consider adding fiber like Metamucil. Biggest things I probably get from the diet, other than the regulation, is odor and gas. Now, odor, you should not have odor unless you're emptying or changing your pouch. And then, yes, it's going to smell, because nobody's poo smells like roses. If yours does, I need the recipe. Gas, again, is very, very much food dependent. So we need to work out which foods give you gas. Things like drinking through a straw, which, from what I recall in my spinal cord days, many of my patients were encouraged to drink through straws. So if that's something you're doing, we've got to work with that to try and minimize that. Soda pop can cause a lot of gas. Beer is deadly, but I'm not saying don't have it. It's just choosing when to have it. So working with you to try and trigger what are your gas producing foods and drinks. So
opting to get my ostomy procedure has given me confidence. It allows me to go out and do the activities I choose with peace of mind, knowing that there won't be a bowel accident or issue to worry about. That anxiety I used to experience is now gone. It has restored my quality of life. Now, all I have to remember is just be prepared, have some supplies with me, in the event I need to find somewhere private to do a change, if necessary. Having an ostomy has made doing the activities I choose so much easier.
Jen, I'm just going to stop. I recognize it's gotten dark in the room because I'm on the East Coast. Would you like me to turn a light on?
Oh, sure. Yes, I can still see you, but yeah, you're a bit grainy if you'd like to.
Okay, I'll just try and turn it on. Okay.
Opting to get my
We got that. Okay, so this hopefully will answer the activities question. There are really no restrictions to activity. Some of the cautions are hernia development, and so we would work with you, ideally with a physiotherapist, maybe GF Strong, chat with people if they're worried about them. We talk with your ostomy nurse, but none of my patients, to my knowledge, have developed hernias. The biggest thing that I found when it comes to activities, and you'll hear it in an audio clip, is the individuals have more free time now, that because they're not spending 2 hours doing a bowel routine. So there's absolutely no restrictions. In the able-bodied individuals, we caution them for things like goalie and soccer or rugby perhaps, but even then they can wear a stoma guard. When I was doing a bit of research, there was an individual with an ostomy playing rugby, no problem. And then wrestling and that, but I don't see too many spinal cord injured individuals doing that. So let's have a listen. So patient said words of wisdom. Be patient with your body to settle down after surgery. Be prepared for things to change and needing to adapt. Move to a disposable bag as soon as reasonably possible. It's much easier and more pleasant to deal with a disposable. Now, just to clarify, all pouches are disposable. What he's referring to is that one-piece closed pouch. I am glad I got my ostomy. There are no perfect solutions, but for me, an ostomy is better than a bowel routine. It is much more dependable and much easier to deal with if something doesn't go according to plan. Much quicker, more comfortable. Fewer blood pressure issues, no more bleeding hemorrhoids. It's hard to make such a big change without being forced into it, but I think it's a viable option for many people and should be considered as a viable option much earlier than I did. I wish I'd done it earlier. Now, this is the second patient. This is not the patient from the audio recordings. And yet the words are almost identical when you read them. The same hemorrhoids, wish I'd consider it sooner. One of the biggest questions was visibility. And I remember going to the individual's home that night. Surgery was the next morning because I had this panic phone call. Lauren, I think we need to put the stoma somewhere else. And, you know, I did go over because that's just who I am. And it wasn't too far away from my work, the home. And so we reevaluated. Now, I can't assure you that things won't be totally visible. This individual in the picture has an ostomy bag underneath. I know you're all going to be trying to see it now, but because you're in a chair, there will be a level of visibility depending on what clothing you wear. The big thing is here we've got a black t-shirt on. It's not that visible. For many individuals, if I hadn't told you they had an ostomy, you wouldn't have realized it. But when you wear a shirt with a design on it, or a loose hanging shirt over top of a t-shirt, nobody can see it. There are a lot of ostomy support groups. So we have the Vancouver United Ostomy Association, and they produce this magazine called The High Life. And I'm always having to tell people that, no, that was developed before all of the cannabis stores and everything, this title. I actually help write for them. It's a phenomenal magazine. Deb Rooney spends a lot of time researching articles, and it comes out every couple of months. I help run the 20s to 50s ostomy support group. Right now, it's mostly by Zoom, and it's a great group of guys and girls, mostly guys, strangely enough, who join it. We've had one in-person meeting since COVID. We went and we met down at Kids Beach area. There's Ostomy Canada as well. I'm what's called, it's kind of weird, a lifestyle advisory member. So they're really big. You can find them on the web. And then if any of you are elsewhere outside of sort of Vancouver, we've got smaller support groups out there. The best is to check the Vancouver United Ostomy Association website, because Deb Rooney keeps updating it with which support groups are actually running. Not all of them are running due to COVID. So I asked my individual patient if he was happy, and these were his words. Asking me if I'm happy that I did the surgery is an understatement. I'm incredibly happy I made the decision and regret I didn't do it sooner.
What is some of the advice I would give to anyone considering this? Well, first off, always do your homework and research just to see what you're getting into. Keep an open mind about everything. I know I found it incredibly helpful just to talk to people who had already done the surgery. Get your questions answered just so you can be comfortable in your decision. Personally, I spoke with 3 different people who had already done this procedure. That provided me a lot of information and gave me answers that made me feel comfortable with my decision. One of those individuals, he was even gracious enough to go over his experience with me. He actually took the time just to show me how he changes his pouch and gave me a lot of really good information. I think secondly, always talk to somebody like Lauren, who has experience with ostomy and with the SCI community. And make sure your doctor, the one performing the operation, has contact with your ostomy specialist. I can't say enough good things about Dr. Milosh at VGH. Caring, understanding, really just an excellent surgeon, tons of experience. I think lastly, look into the costs. The supplies are not cheap. Be sure you have some sort of coverage, either PharmaNet or PharmaCare, Extended Health, or some sort of plan that can pay for all or most of your supplies. Unless you have the means financially, it can be rather expensive over time.
So we're coming to the end of the presentation. So I work for McDonald's Prescription in the Fairmont building. As mentioned in my bio, I work there many hours. When I'm not at VGH 3 days a week, I'm pretty much at MAC. I work with a lovely group of nurses. So I have Heidi, who's actually on mat leave, Candy, who, it's amazing, she's a nurse practitioner and a wound ostomy continence nurse, so that's very helpful. And Chris Kwong, she also works with me at VGH. And I actually just recently hired a young girl, Janice, who's just finishing her training. We run a clinic 6 days a week, but we're only there if patients book in. So not 6, 7 hour or 8 hour days. The hours are varied. As I said, 4 wound ostomies, 1 WS nurse practitioner. The staff are incredibly knowledgeable there. And appointments are free with the purchase of ostomy supplies. We do a bit of continence, as you can see. We do sell catheters as well. Our background is not as extensive in continence as a continence advisor, although we've done a similar training. We haven't done as much practicum as they have, but definitely when it comes to selecting catheters or navigating trauma or any of that, we're absolutely happy to help. And I have had a few individuals come into the clinic for that. If you need to reach me, my email's up on the screen. I can put it in the chat later, and our phone number for the store is there, and you just leave a message for me to contact you. In conclusion, I really want to say, ask questions, explore your options, and find the best solution for you. Because having an ostomy, as you've heard, is amazing. Everyone said it's great, but it may not be right for you. So you need to investigate all of it first. You need to find out your surgical risk factors. Are you able to have an anesthetic? Is your heart stable? All of those factors before you go to the lengths of getting an ostomy.